something really special lined up, our webinar titled Frontier in Pediatric Palliative Care and Insight from Palliative Care Pediatrician. Thank you so much for making time to be here with us. Now, when we hear about the term palliative care, many people think only about the end of life support. But actually, it's more than that. Pediatric palliative care is much more about helping children with serious illnesses live the best quality of life as possible right from the time of diagnosis. And today, we are going to hear about some of the latest approach and real life experience in this field, from symptom management to supporting families to making healthcare more compassionate. And of course, the highlight of our today is our speaker, Dr. Fahisham. It's an absolute pleasure to introduce to you our senior consultant, pediatrician, and senior lecturer at Hospital USM. A little bit about Dr. Fahisham. He started his journey in medicine from University College Dublin in 1999. He then went to obtain his MRCPH in 2009 and has been serving as a pediatrician at USM since 2010. His areas of interest include pediatric palliative care, child abuse, and also domestic violence, fields that require not only medical expertise but also a lot of compassion and advocacy. Beyond clinical work, Dr. Fahisham also has been actively involved at both national and international levels, contributing to the Cancer Pain Clinical Practice Guideline (CPG) in Malaysia, and also serving as part of the WHO Guideline Development Group on Women's Violence. And on a personal note, Dr. Fahisham is also a proud father of 7 children. So you can imagine how much he understands the world of children, not only as a doctor, also as a parent. We are truly fortunate to have him with us today. For the audience, if you have any question, you can feel free to write in the chat. So without keeping you waiting any longer, let's welcome Dr. Fahisham to share his thought on frontier in pediatric palliative care and insight from palliative care pediatrician. Dr. Fahisham, over to you.
I'm sorry, my camera is stuck making trouble now. I don't know lah, last minute punya problem ni. Anyway, I will try to switch on again. I mean, if it's not working, I'm sorry lah. Okay. So let me just quickly share my. Okay, can you see the PowerPoint?
Yes,
Okay.
Okay.
Okay, thank you very much, Idlan, and also IPPT team for inviting me to give a short talk on pediatric palliative care. I'm acutely aware of timing. I mean, like, I don't think, 5 o'clock in the evening, especially for Kelantan timing. I mean, everybody has gone home already because tomorrow will be a holiday. And my task is trying to stimulate sort of discussion on pediatric palliative care, which is kind of challenging. I mean, to cover from first page to the end. But I will try my best to kind of like cover a few areas, which I think important because I believe most of the listener for this talk just only general, and then maybe some of you have encountered already cases of pediatric palliative care. Some of you may not. So I think generally this is a talk just only to give a taste of what pediatric palliative care is. I don't think I'm going to go into cases just only, I mean, gist of the cases. Yes, I will do it, but not overall of the detail of the cases. I'm also aware that Idlan, let me know if there's my time is finished. Let me know because I don't know. I mean, hopefully I will talk within the time frame that was given, not to be too waffling around the topics. Okay, so let me just start. Okay, so these are my outlines. I'm going to talk about what is pediatric palliative care at a glance only, and then what happened in Malaysia, and then what's next, and hopefully come with a conclusion. I mean, like just only simple conclusion from it. Okay, I think we perhaps is considered as a new kind of like subspecialty, even in the UK or Ireland or Western countries. I mean, like this is fairly new specialty, and often the moment I started the pediatric palliative care, that was the time when I came back from Malaysia. And when I came back from Malaysia, I didn't know about. I mean, obviously there is oncology palliative care over there, but I don't have that much interest of doing pediatric palliative care until my return to Malaysia. And when I returned to Malaysia, I was not greeted. I was responsible to take after challenging cancer patients during 2010. And I believe at that time, looking after cancer patient can be fairly challenging because A, they present very late. B, they were using a lot of traditional medicine as well. C, I mean, like the lifespan of children at that age when they present very late is fairly short. And unfortunately, we don't have any specialty to kind of manage the symptoms of patient with end of life and with devastating kind of like disease. Okay. So yeah, hopefully I can go through with you journey to look at pediatric palliative care at a glance. As we know, population has exponentially risen, because of the availability of modern medicine, because of the vaccination, because of the technological advancement. Yeah, we all survive. I mean, like if you look during the time where the modern medicine has not yet developed, I mean, like the lifespan is fairly short. But then, like, it's growingly. I mean, as you know, we're getting better at managing life. But then, like, if you look at the death rate, what is our death rate? I think everybody knows that. I mean, like in at our back of our mind that whenever we live, I mean, all of us will die. So basically, the death rate is always 100%. So we all, whether you like it or not, whether acutely or chronically, um, everybody is going to pass on. So yeah, the death rate is always 100% for everyone in this world. To simplify, palliative comes from the Greek words as pallium, and pallium is to cloak. Cloak means that you have a kind of like cover. So what does it mean to cover? To cover the symptoms, hopefully to ease whatever the suffering that they face, and this is perhaps used during the time when the death is approaching. Perhaps the philosophy behind it is trying to maximize the quality of life, to give enough spiritual and psychological support. This is by literal kind of like meaning of it. In essence, I mean, if you look at the WHO 1998 and then the subsequent to it, there are so many other definitions, but all these definitions kind of like entail similar body embodiment of the principles. One is that we have to be active and total. So palliative care is not passive. Palliative care is not about leaving the child behind to the dark room and without doing anything. So it's about active for managing the body, mind, and spirit. Okay, so focusing on the child and also focusing on the family. We notwithstanding that the child is facing kind of like devastating disease, but we also need to look at the family for support as well. So Ilan mentioned earlier on that it should starts at the time of the diagnosis. The diagnosis is related to the life-limiting condition as we spell it out. So when you know that the condition is life limiting, this should begins kind of like introduction of palliative care. And what it aims is to improve the quality of life. So this is more kind of like kind of like general. how to improve quality of life, quality, reducing the suffering and etc. And also require multidisciplinary. So it will require a lot of people to come together to a similar goals of care. We have to be similar. I mean, what we don't want is that doctor has goals of care is trying to try to improve quality of life, and the other team member maybe have got goals of care for curative. So that can be divergent of goals of care and leading to kind of like difficult management. And it can be provided in various settings for children with life-limiting condition. In essence, if we look at the conceptual framework of this, I mean, like it has to be the whole person, the whole family, the whole process, and the whole team and community. So what it meant by the whole person is that we have to focus on the person or the patient themselves, related to their needs, related to their requirement, and related to the management of the patient. Similarly to the whole family as well, as we know here, let us focus on the whole person. We kind of like when we are looking at children has a diverse kind of like group of age group basically, and the requirement for all of them may be different from one another. For example, like consent, all of them require consent from the family in order to give consent in terms of treatment. The needs also can be different. I mean, neonates, infant, toddler, perhaps their needs is about love. Their needs is about being with the family members, rather than adolescent. Adolescent is perhaps their needs are very much different. They would like to be more around their peers, and they would like to be more independent. So the needs for each and every age group will be very diverse, similarly to intervention, similarly to drugs use, similarly to developmental milestones, spiritual development, and etc. But as we know as well, palliative care is not only per se focused on children, but then it now has diverse kind of like, kind of like having a spectrum, okay? One, I mean, I think it has, kind of like evolved into, focusing again to the uncatered group, for example, like perinatal group, parental age or babies. And this perhaps is also a new phenomenon for us. I mean, looking at how we can manage the family members and try to make sure that the quality of care, quality of life has been preserved well, and how to approach on this very much sensitive issue of maternal pregnancy, and then when they come out as a baby, and giving them bad news and communicating on what the prognostications are. So I think it has evolved as well. So similarly on the other group as well, if you look at the spectrum, so when you look at the adolescent and young adults, because of their determination of being free or being kind of like having their own ways, or having their own mind of making decision. So we are dealing with very much different, kind of like problems, perhaps related to their body image. I mean, I have a case before where an adolescent who was under the adult team, but because the cancer grew over on the face, and that's distorted their body image, so she was not able to face her own self, and requiring a lot of psychological support, and was not willing to look her body in the mirror. So that can be a very challenging issues as well, and they probably, I mean, like perhaps have some other aim and ambition, because they want to work like a normal adult. They want to have a spouse. They want to have families. They want financial independence. One of my patients before, we have is a Chinese a man, not man, adolescent. I mean, like a young, he survived because of the hypoplastic, if I'm not mistaken, it's hypoplastic left heart. He's got cyanotic heart problems, and he wasn't able to walk even for a meter or two, and he was dependent on the oxygen. When he was asked what he wishes for, I mean, he wished to work, I mean, like be financially independent, wish to have some income so that he can help the families. He wished to travel to Thailand as well. I mean, like that. There was a time when he wasn't sick. He was sick, but then he also had wish, which is very much different from other group of children. The second part is that we have to be aware as well that when we are dealing with the families, because in essence we don't want to become paternalistic. We are the one who make the decision for the family and the child, or the other way around, the family or the child making the decision for themselves. So I think what we need to do is try to guide um, families and even children with good understanding about what they want to achieve in terms of quality of life, in terms of wishes, in terms of making their wishes come true. So I think these are the things that also, I mean, like if possible, rather than too extreme being consumerisms or paternalistic decision making, we would like to have a decision making that can be shared together between the family members and also the physician who are managing, so that, I mean, like the family would not be felt that this is a burdensome for to make the decision, and also we don't let them to make a decision which might cause harm for them. But again, I mean, like Idlan mentioned earlier on, the palliative care should start early. I mean, when the patient has been diagnosed with active disease, I mean, we should introduce, because I think the key here is that not because, I mean, like we may have some, like for example, like cancer patient, we may have curative care at that point of time, but palliative can kind of like support looking at the psychological needs, looking at the knowing the family members until the disease starts to get aggressive, where palliative care is much more warranted rather than the curative care. And that's where, when you reach the time where there's no treatment availability, then you reach at the end of life. So I think palliative care should be started early and throughout the end of life care until the bereavement, whereby you can support the family members following the death of the child. This is just only illustration as well, just only to illustrate, but this is for adult basically, but I'm just illustrating if you have a life-limiting condition. When you have a life-limiting condition, you might be stable. So the requirement for stable may be slightly different when you start to have crisis or unstable episodes. You know, the disease start to get worse. You get hospital admissions. The disease become unstable. When you're treated, you might not reach the same what you call health status as you were previously, and at that point of time the requirement would be very much different. I mean, like maybe the requirement, for example, like when you're stable, is to discuss in terms of advanced planning, discuss about, initiate the discussion, the understanding of advanced care planning. But when you're deteriorating, you might want to discuss about what you want to achieve in terms of goal of care. Do you want the CPR to be done on you? What do you want to do in terms of your wishes? Who do you want to get the your family members to look after you? Who do you want to, what are the rituals or spiritual things that you would like to get beyond the time when you reach the terminal stage? Okay. So the needs will be very much different. I mean, like if you discuss about the needs of children, as I mentioned, depending on the understanding of the child. But then, like as I mentioned, I mean, you are going to go into different phases the phases where if you reach the diagnosis of life-limiting condition. I mean, imagine if you, I want to illustrate for maybe, a case of life-limiting condition in children. But let's put ourselves in the shoe of a man, and then you hear yourself that you have cancer or motor neuron disease. So when you're diagnosed with motor neuron disease or some condition related to life-limiting condition, your needs will be very much different. Perhaps at that time you try to console. Perhaps you're having this issue related to denial or anger. So the moment you reach down to the news about life-limiting condition, there's a lot of psychological effect that might happen to you. And in between, as I mentioned, you probably will have a crisis. So you perhaps going to be admitted because of certain certain acute admission, infections or deliriums or breathlessness or whatever. So these are need to be managed in terms of symptoms relief. And then when your health status is becoming worsened, you can look at your ability in terms of function. You probably before this you are able to do it on your own, despite having a life-limiting condition. You probably would be able to roaming around, paying your driving car and etc. But when you are gradually unable to do so, when you're becoming bedbound or you becoming an inability to talk or to converse, and this is where your needs change again. Similarly to when you're terminally ill or when you are going to pass when you're going to die. Oops. Okay, so the tale of two worlds. I like to bring this. I mean, because I think if we reflect on ourselves as a healthy person, perhaps our priority will be maybe, I mean, like as a doctor, maybe you look at your work because you probably wanting to achieve whatever goals that you have in this world. Your work, maybe to becoming a senior lecturer, to becoming a associate prof, and then professor. So your work will be priority. Maybe the other part of it related to the house. You want to have a good house. You want to have good family members, which can kind of like stabilize your career span. You probably want to have a good kind of like car as well. You probably won't focus that much on the health and spirituality because I think, I mean, every doctor's like me as well. I mean, although you kind of like visit the health clinic to check your blood, but focusing on the work or the health, I mean, is perhaps not that essential. But then, like when you reach the diagnosis of an ill person, so perhaps your focus would be related to more of your health, the family, and also spiritual. So the work perhaps has been pushed aside and trying to look in terms of getting your health back. But all these will be very much different because in the age group, the focus or priority in life. I mean, for example, if you're young, perhaps you're looking for peers recognition, peers, friendship. But when you reach certain age limit, you would like to build a family, and therefore you would try to find a spouse. And when you reach a certain threshold of age, then career become an essential part, and then health. When you reach the retirement period, and after that you look for the spirituality. But then if you reflect to children, perhaps their needs are very much different. I mean, like I put it on the left side there. Maybe being loved to from the parents. Maybe play, because this is their work. Food, because I mean that will kind of like improve their, they want to have food. pain, reduce the pain, touch or attention. I mean, like, these are the things that, um, kind of like reflecting of the needs of children rather than what the needs of an adult, healthy or ill adult. But again, I mean, like when you focus on all these parameter, you also need to be acutely aware that palliative care does not deal per se on physical. Yes, physical is important. For example, like if you have pain, you want to have a control to the pain. The physical management is important. Whether this is from the drugs that you use, whether this is from the non-drugs approach, or whether it can be, related to other intervention, for example, like radiotherapy because of the cancer in the bones. So physical disease symptoms is important. Imagine if you are uh, uh, a person who have toothache. So if you don't control that toothache, you're gonna be grumpy. You're gonna be, kind of like difficult and challenging to to your peers because you are not in the good state of mind. But then like you also have to look at other elements, for example, like psychological, because psychological, I mean, when you have pain, you probably will have anxiety. When you have anxiety, it's affect psychologically. So in terms of managing all these responses, because if you can't control the pain, you probably won't, yeah, you psychologically will be much more affected. You also need to look at the social part of it, because I mean these are all related to relationship or the values of such a person. So if you have trouble with your family members, perhaps that will also affect the outcome. I mean, you probably will feel pain, isn't it? For example, like imagine if you lose somebody who's very valuable to you. You can feel the pain in your heart. So spirituality is also important. For example, like if you get a life-limiting condition and suddenly you kind of like blaming God or blaming, yeah, God for your existential problems rather than looking into a different paradigm. But palliative care, end of life. I mean, palliative care, perhaps when you are being diagnosed with life-limiting condition, you're fairly stable. The focus is maximizing quality of life. You might have curative or palliative or curative together with the palliative kind of like treatment. And when you reach end of life, which some definition looks into weeks or months to live, so perhaps it's to get some support, symptom care plan, and also spiritual. When you're terminal, therefore, again, symptom control is important. This is when the time where the lifespan is shortened. And you want perhaps looking at the dignity or perhaps looking at the needs which are much more different than the time when you are being diagnosed or end of life. So I think I'm just emphasizing kind of like similar things, but then in different time frame. Okay, so these are some of the example of the disease. For example, if the disease, if you this is an adult basically. So for example, if you have a cancer, okay, you might be okay until the cancer starts to take over your health status, and then you might deteriorate very quickly into terminal and then death. Trajectory number two is more related to the organ failure. If you have heart failure, liver failure, you probably will be okay at certain time. And when you have a crisis, your health status will dip down, and then you get treatment. You might not reach this previous similar health function. So it deteriorates slowly, and then you get another crisis until at some stage the crisis and you don't improve anymore. And the third one is about frailty. So I don't need to focus on this because these are adult. But what I want to focus perhaps is the children. Who are the children required for palliative care? Obviously, this is a challenging topic because I mean palliative care in adults more related to organ and cancer. This is very much the themes. Whereas in pediatric palliative care, we have one group one, which is a cancer, perhaps when the disease is getting worse, and then your health status will drop. If you have cured by chemotherapy, then you're back to normality. Group number two is those with a condition where intensive long treatment would be kind of like available. For example, like cystic fibrosis, you probably will be worsen, and the treatment is there, but to prolong kind of like, so they live perhaps up to 20. So other condition may be related to muscular dystrophy or some other condition related to immunodeficiency as well. The third group is those with a condition where treatment is exclusively palliative. So you don't have any availability of drugs which can help to prolong. For example, like metabolic disease or chromosomal. So your condition just starts to deteriorate very rapidly, and your lifespan is going to be shortened. The fourth one is the group where, for example, like cerebral palsy, where they are non-progressive, stable, but then because of the risk of complication due to RAS tube insertion or vomiting, and you gradually getting worse, but then like you perhaps if there's a treatment available, overcome the illness, the patient can survive, but then it will not reach similar health status as previously until some stage. I mean, nowadays CP lives longer, maybe up to 20. I've got patients who live longer. So the problem right now is to think about how to transition them to adult services. And obviously, the team and community, we probably have a lot of people, I mean, like to work together in a team. I mean, like, obviously, if we try to emulate whatever happened in Malaysia, this can be pretty challenging because, I mean, I think the community base is not geared towards palliative care provisions like in the UK or in other places. So we do have community care, but it's all focusing on the prevention rather than the strategy for palliation and supportive. They might have domiciliary, but domiciliary perhaps for a certain time frame, not for a longer period of time. So I think these are much of a challenging features in our setting. So as you know, pediatric palliative care works with all team in order to reach similar goals of care for the family and also for the children themselves. What different from adult palliative care? Is because it's rare. Like I mentioned earlier on, you have genetic condition, you have immunodeficiency, you have metabolic condition. These are rare and not kind of like being seen. So even if you have the ability to prolong life, again, all these children, whether the adult is ready enough to adult palliative care, whether they are ready enough to kind of like accept this rare condition, because their assessment and also their group of palliation group will be very much different. The different age group, I think, as a pediatrician, I think these are the challenging part. A child who kind of like suffer from leukemia, for example, they might not be worried because they don't know about the condition. But then, like, upon looking at the maybe responses from the family members, they would react to similar to the family members. Whereas in children who have understanding in the school age going, they want to know what happened to their body instead of being poked, being taken bloods and everything. So they want to know. But then, like, we are in a serious challenge because the parents may not want the information to be given to them. Also, we are encounter parents as well as caregiver, because I mean, like, parents has got the ability to give consent for whatever treatment, or even to kind of like issue a palliative care straight away. Some of the things, I mean, we have to negotiate with the parents in order to reach whatever goals of care together. The drug of choice, this is because of like a baby has got different volume or dose of bloods compared to an adolescent. So I think the drug of choice can be very much limited, not similar to adults because of a lot of the body the organs are very much not reaching mature state yet, and therefore handling some of the drugs can be pretty challenging. Decision making, I mentioned maybe parents, an ethical issue maybe related to the consent, confidentiality, and some other issue related to the ethics. So in essence, palliative care, hopefully we could control the symptoms, therefore thereby really relieving suffering. We could reach whatever the goals of care in terms of their value, preferences. We could support the family members. We could make a good communication and also follow up in the bereavement phase. So let me just go. I mean, I think I took a lot of longer isn't it, for. So in terms of development in Malaysia, so palliative care should be a human rights. What we don't want is that when we talk about palliative care, is that we want, okay, we don't know what to do, and thereby abandoning the patient. I mean, like not giving the right or best treatment because okay, palliation, okay, just keep TLC, just make sure that the patient receive whatever drugs available. So I don't think that's the right way to approach palliative care. Palliative care is more about humanity. Palliative care is not about abandoning the patient. It's not about not knowing what to do. We should be able to know. I mean, like the 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 approach. If you have difficulties in terms of looking after the physical symptoms, so you can look after the psychological part or social part or spiritual part. So this can be discussed. I mean, like whether pain can be originated from one of those or mix of those. But again, I mean, like we can discuss about what they feel, and this should come into a common sense. In Malaysia, it started in 1991 with the NGOs, and then the Ministry of Health started on palliative care. And after that, it extended to the medical schools. And afterwards, the creation of pediatric palliative care, perhaps around 2012, and advanced diploma in 2014. And recently, there was a discussion to incorporate domiciliary care into the palliative care service in Malaysia. For pediatric palliative care in the past, I think what happened is that we only have level 1 universals, and level 2 is just only managed by the pediatrician, or if children over 12 admitted under adults, perhaps it's being managed by adult palliative care rather than pediatrician. But these maybe focus on life-limiting condition, cancer, and chronic illnesses. Whereas in the community, some of the children, I mean, if they are over 7, can be managed by the adult hospice. In 2018, this has changed with the new kind of like with some of us coming home from training. We are fortunately to have some of the hospitals being equipped with level 3 kind of like pediatric palliative care physician. And also nowadays the Ministry of Health has introduced advanced care diploma for palliative care nursing, plus MAPAC as well. I think nowadays as well in IPPT, there's also fellowship of palliative care nursing as well. So I think it has got evolved to a certain extent, and so many things has been well supported and well maybe trained. In 2019, the Ministry of Health produced a national task force, which looked at what the strategic plan in terms of reaching these, goals for palliative care in Malaysia. It is kind of like monitored by research standard, and there is also service implementation from the hospital community and also pediatric palliative care, with the enabler kind of like using education, essential medicine access and also sustainable funding. So you go back into now in 2020, it has become more advanced and with a lot of education by personal, by individual, kind of like doctors, and creating some of the guidelines as well. And also, what happened is that they also produce a guideline for national training for NTP, national training for pediatric palliative care program, whereby people can come in from different walks of life in terms of learning palliative care. And we have also handbook, and the last time is that it has expand to have hospice, Malaysian Child Hospice in KL, Cebu, and Klang. So what's next then? I think this is very difficult. I want to be grounded to whatever we want to achieve. Don't want to be too bombastic in the approach of palliative care. We knew already that the landscape of medical medicine has changed. Before this, we often focus on acute medical condition. We have equipment, we have a ventilator to focus on. But now, as we have those, we also have those with a lot of life-limiting conditions survive. For example, like cerebral palsy. This cerebral palsy is not that bad. If you have, severe kind of like severe cerebral palsy, they might not be able to use their legs and walk, and therefore, this change of medical landscape has urged us to be rethink of even in palliative care, right? It doesn't mean that when you label as palliative care, you should abandon and not doing anything. So in cerebral palsy, we also incubate the patient. What we are trying to achieve is to get similarity in the goals. Okay, to get similarity, I mean, like to everybody to have thinking about advanced care planning or advanced directive as an adult, to have a, rather than having a polypharmacy management, to be sanctioned, to be sensible in terms of management of drugs, to support in terms of psychosocial issue, to have a plan like parallel planning and symptomatic care plan when the patient goes home, and to decide on where the place of care in terms of managing the patient who are maybe dying or palliative care. So the goal of care, if you look at the goals of care, sometimes the goal of care is when they are just on the palliative phase, to make sure that it is comfort, and you should try to look at the you should try to look at the how you can reach the comfort, good quality of life, because survival perhaps is not a priority at that point of time. The second part is maybe if the child is dying, then again we probably look at the comfort care as well. But then, like some of the things, artificial nutrition may not be needed as the child is actively dying. So I think our identification of the phase whereby the treatment is indicated or not indicated is essential. And the other part of it is that I also discuss about the ceiling of care, which means, I mean, what maximum, things that we can do if a patient comes to the hospital. Sometimes you decide where, okay, this ceiling of care is perhaps is using BiPAP or CPAP. I have got a case before of spinal muscular atrophy, type 1, severe one. I mean, like the patient comes in and with respiratory distress, we decided not to intubate. What we often do is the trying to get the as much what you call as much symptom control, and also give oxygen to the max. What we can do is the max, for example, like high flow oxygen. So the next one is about advanced care planning, because advanced care planning is a record of discussion. So the discussion where you can kind of like write your wishes, what you want to do. I mean, and then give the autonomy to them to make that decision. Because I think, I mean, like in Islam, perhaps we have a will, isn't it? A wasiat, a will that we want to do. But this is not a will or anything like that. It's not a legal document. It's just only a record of discussion, whatever discussion that we do in terms of if you're, you know, if you're in terminal stage, what do you want to do in terms of when you are not able to talk, who's going to look after you in terms of if you're terminally ill, do you want to get somebody to be close to you and holding your hand, and you know, or perhaps spiritually you wanting to get the, you know, you know, when you are not able to because you're a spiritual person, you want to pray, you want to get somebody to kind of like give ablution to you and etc. So I mean, adolescent will be very much different. If a child, then obviously the discussion will be more with the family members of or the parents in order to reach the whatever goals of care, yeah, that we discussed earlier on. And hopefully with this communication, we can reach in terms of short-term and long-term goals. This is flexible. You can change at any time. It is not a legal document, but it's good to have it because, I mean, if this patient arrived to certain hospital, and from this hospital they know already that discussion has been made and decision related to CPR or drugs or, you know, whatever invasive procedure can be minimized. In terms of place of care, I think a lot of Malaysians wanting to stay at home. This is an adult, but again, I mean, we don't have this in children. But I assume a lot of them, depending on the factors related to the child, I mean, whether the family is are able to cope or not living with child with the condition, because yeah, these are all new. I mean, if you have a child with cerebral palsy, perhaps, I mean, the child has been living for a long period of time, that will be okay. But if you have a child who's perhaps is being diagnosed with cancer, it's a new thing for the family, because family has to become a support person, family has to become a nurse, family has to do a lot of things, and also being as informal caregiver can be burdensome and also challenging. What are the family concerns looking at the you know, condition where the child might die, or maybe related to the circumstances related to the family members? Practicality, I think what we don't want is that when we discuss about palliative care, we don't want it to be, I mean, if we do research, it's just only being kept in the ivory tower in the university without being, you know, applicable, practical to the community. So I think whatever we want to do, hopefully, I mean, we need to make sure that it is useful and can be used in our own context. These are some of my patients. I mean, my patient, this is the one who's got, if I'm not mistaken, soft tissue tumor, who basically invaded the face. He didn't want to come to the hospital for chemotherapy, not responding. And also he passed on at home. This is a child with a very cachexia child. I think he was bitten by snake and then he was a normal child, bitten by snake. Unfortunately, he ended up with cerebral palsy, and he also passed away as well. This is the one that I dealt a lot in the past, where he came around during the COVID time, where she had a very big ovarian tumor, rare ovarian tumor, which compressed her stomach and also chest, causing restrictive lung problems, and this is similar. I mean, I call her for the exam in the past, and then to see and then to do the scan as well during the COVID time. This is a child with SMA, who I think still survive. Well, I mean, he is, the weird thing about palliative care, although we label it as a life-limiting condition, SMA is life-limiting condition, but because of the availability of the new drugs, and he was taking that drugs, and he survived up till now without any what you call complication or admission. I mean, like admission to USM for quite some times already. So I have adolescent as well who also has got soft tissue tumor. He also passed away as well. He's the one I discussed that he didn't want to look into the mirror because of the image that he had. He was very cachexic at the point that we saw her. And then this is the biliary atresia baby who we had a birthday party together with the Yogurt team as well. So in terms of good death, yeah, I mean, if we talk about good death as well, I mean, like component of, I mean, this is not being explored in our society. Basically, what does good death mean? Everybody has got their own pretext of what good death means. For example, like for patient, these are the list. For caregivers, maybe these are the list. This is the study that was done in Hong Kong. So their list perhaps will be very much different, looking at good life, good death, and also good separation. So I think the understanding of good death perhaps is different when you look at the prophetic ars moriendi or art of dying. um, you look at certain condition has been mentioned, even for Muslims as well. I mean, although the belief of good death in Muslims sometimes related to the timing, Friday, maybe related to certain understanding or ritual, or reading Quran or praying, whatever. But one of the study that was looking into Muslims as well, they outlined 12 of them, looking at the perspective of death among the patient and healthcare providers. So what you can do, I think these are the things that when you're dealing with wider age group, diverse background, culturally, religiously. I think the thing is, I mean, you probably we can divide into three phases. You can think of your own. What can you approach in terms of physical, social, spiritual, and psychological? And perhaps related to, I mean, like when you start to slowly deteriorating, what do you want to do, in terms of maybe some people wanting, hopefully they are going to be close to God, maybe legacy in terms of, leaving legacy to the family members, maybe quality of time. Time is very, very much essential to be looked after by somebody whom rather than somebody who are, foreign to you. Nurses, maybe you don't know them, but if you have your wife, your parents looking after you in a bed, that will be much more better. And also, other than that, related to maybe place of care or place of death, or where you want to bury the body. So in terms of end of life, I think what I want to touch here about 4 wishes of Aubrey. This is a child, baby who's been under the neonatal intensive care unit. So he had severe congenital heart, and also omphalocele, which is the gut coming out. So the wishes of, thank you, Ilan. The wishes of the parents, A, to make sure that the patient Aubrey is going to be looked after by the family member. B, they want to have a family photo together. C, mother want to sleep together with Aubrey because of Aubrey has been in the what you call incubator for a long period of time. And also mother wants to bring Aubrey out in order to feel for the breeze of air. So I think end of life, it doesn't mean that you need to do a lot of things spectacularly. You probably can do something simple than that. So in research, in our context, it can be very challenging because you may have a small group of population. You are going to be dealing with a lot of ethical issues, vulnerability, but then, like, it is very important because we need to answer a lot of things in terms of outcome, in terms of symptoms, in terms of infrastructure, in terms of so many other things that we have yet to explore in research. So I think this is the key that perhaps, I mean, I think it's like a gold mine that palliative care needs to get it done. Even though in contextual time, it can be very challenging because of the ethics, because of the vulnerability, because of studying patient who's death and dying, so that can be very challenging. So in conclusion, I think I think pediatric palliative care is a new area, so we hope at some stage that it will expand. It will help more children who are facing, life-limiting condition, and prepare them eventually, and also support the family members facing the difficult time and turbulent time. Many of the things that need to be answered. So we have different population. For example, like I mentioned earlier on, a group of children with different population, their needs perhaps are very different. We want to answer a lot of things as well, which treatment is basically better in different age group. Because I think the utilization of drugs can be very much limited, and also some of the gray area like end of life. If you want to study all this area, I mean, like, who's willing to give it, because it is a very sensitive issue, and very much in order to discuss all these sensitive issue, it has to take a lot of guts and courage in order to come up front and discuss on the difficult task, because this is culturally very taboo. I think with that, many thanks. I'm sorry my video is not working again. So I think I will finish here and leave back to the moderator. Thank you very much.
Thank you so much, Dr. Fahisham, for such a helpful and eye-opening presentation. So for the audience, can ask question in the chat box. Meanwhile, I have one question or two.
Okay.
It's empat. In our current setting, we as medical officer ataupun general pediatrician, how and where we want to refer palliative pediatrician?
Okay. Okay. So pediatric palliative care, as you know, it's not a lot basically. So the people or the healthcare provider who provide pediatric palliative care, at the moment, I mean, like, there's one in Kelantan, there are two in Lembah Kelang, perhaps two in Penang, and one in Cebu, and one in Sabah. So basically, I mean, not a lot of coverage. But again, even though there's not much coverage, I mean, it is essential that everyone with, like I mentioned earlier on, I mean, like, we have a triangle there. It does not need to be, I mean, like, the children who are undergoing for pure symptom control, there are not many. For example, like specialist symptom control, the one with terminal ill, or the one who require a lot of morphine. I have one now who's got osteosarcoma, Ewing sarcoma, who's on 4 patches of fentanyl 25. It's about 200 plus milligram of oral morphine. So I mean, so that one, I mean, it's not a lot. So what you can do, I think everybody should be equipped with palliative care kind of like skills. The skills to communicate, the skills to manage the psychosocial part, the skill to discuss on the spiritual issue, the skills to answer if the patient asks you, okay, what happened to me? Am I going to die or not? So the skills of answering those things. So I think to be there with the patient. I mean, like, imagine to be there with the patient, and if you reach some difficulties, for example, like, oh, I cannot manage symptoms right now, so you reach to the palliative care physician in order to kind of like discuss on what do you do. I mean, I think everybody can do it. With some guidance, with some connection. So I think that should be the way forward for the time being, until we are equipped with many of them.
Okay, there's one question.
Okay, Dr. Intan, Prof. Intan mentioned about challenging with terminally ill, and I believe even pediatrician should have a debriefing. I think this is important, because once you're managing with ill patient, death and dying, I think you have to reflect back. This is the debriefing, okay, to say that, okay, what have you done good, what you've done, what you can improve. So as a reflection of what you do, and then leave everybody to kind of like debrief and discuss on the matter. Because if you keep it to yourself, if you don't have the boundary, unfortunately, you are going to go and have a burnout as well. So that's, you don't want it to be burnt out. So one of the key things in dealing with pediatric palliative care is to have a self-care, to know how you can look after yourself. Because obviously what you're doing is you're trying to kind of look after in order to look after the patient, you need to look after yourself. If you don't look after yourself, you're gonna get sickness, and you won't be able to look after your patient.
Okay. There's 1 minute left. Mm. I have one last question.
Okay.
Okay. So, ideally, the children of patient should know the diagnosis of the illness, lah kan? So, if let's say at what age must the children should know, and if we can intervene if the parents doesn't want the children to know.
Okay, so I think this is there's no age, which age, because like I mentioned earlier on, the understanding of children may differ depending on their developmental progression. So the information, I mean, like for example, like information about leukemia in a 3-year-old or 4-year-old may not sound anything harmful for them. So if you tell them about leukemia, they might not understand anything. Whereas a patient, perhaps 6, 7, who has been in the hospital for a long period of time, who kind of like undergo a lot of stress period. So they understand in terms of the condition, because they have to undergo chemotherapy and also blood taking procedures and painful. All these painful procedures make them a little bit mature in terms of understanding. So that's number one. I think there's no hard and fast rule when you want to break the news about that. Number two, obviously, in our negotiation, when we discuss with the parents have the say whether to break the news or not to break the news. Because if you break the news and the parent doesn't want to do it, you're going to lose your patient. The parent might not trust you. They might not want to kind of like being under your care anymore. So then I mean, your moral conscience, you cannot really tell lie. If you being asked, you cannot tell lie to the patient or to the parents. So what you need to do is to negotiate lah, basically. I think you cannot tell lie, definitely, but then you can negotiate how many percent of information that you can give to which information can you, selective information can you tell the child, if the child ask you about the condition or the disease. Because what you don't want is that when there is a friction between the healthcare professional and the parents, they might not come back to you, and they might not allow you to even visit in their home as well. So this is very challenging. So what you need to do is to negotiate what things can be told, but you need to be clear as well that you are not allowed to tell any lie to the child. So I think those are the key things. I mean, it's about negotiation here. Time will heal. Some will accept, some will not. But you don't want to be doing mutual pretense, or you're trying to act everything's okay. You're treating okay, whereas I mean the child may requires information and reflect on their behavior as well. Okay.
Okay, all right. Thank you so much, Dr. Fahisham, for sharing knowledge and experience so generously with us. We hope today's session has given us new perspective and maybe even inspired us in our current practice lah. So I think that's all for today. Thank you so much, Dr. Fahisham. So take care, stay safe, and we look forward to seeing each other again. Okay.
Okay. Thank you very
Assalamualaikum.
much, everyone, for
Okay.
listening. Okay.